So this Mullerian agenesis comes under a category of class 1 of Mullerian malformation. Okay, so as we know, one Mullerian duct will give rise to half of the uterus, half of the cervix, and half of the upper part of vagina and one side fallopian tube. So we are discussing about Mullerian agenesis. So Mullerian agenesis comes under class 1 of Mullerian malformation. Right? So the problem with Mullerian agenesis is that the Mullerian duct is not formed. So since the Mullerian duct is not formed, it will never lead to the formation of female internal genitalia. So what are the female internal genitalia? The fallopian tube, uterus, cervix and vagina are the female internal genitalia. So once this Mullerian duct is not formed at all, so then there will not be any formation of female internal genitalia. So when there is no uterus, the female will never experience any menstruation, right? So then she is a case of primary amenorrhea. So ideally, one Mullerian duct will lead to the formation of one side fallopian tube, half of the uterus, half of the cervix and half of the upper part of the vagina. Now you may have the doubt that why it leads to the formation of half side of the uterus, because ideally there are two Mullerian ducts in a female. Okay, so these two Mullerian ducts will actually fuse to form a single uterus and a single cervix and single vagina, right? So one Mullerian duct will lead to formation of one side fallopian tube, half of the uterus, half of the cervix and half of the upper part of the vagina. Where does the lower part of vagina comes from? So the lower part of the vagina is actually coming from the sinovaginal bulb of the urogenital sinus. Sinovaginal bulb of the urogenital sinus, the lower part of the vagina is going to form. The half of the upper part of vagina is going to come from one Mullerian duct and half of the upper part of vagina is going to come from the another one Mullerian duct. So similarly, and the other Mullerian duct is this. So this will lead to formation of one fallopian tube, half of the uterus, half of the cervix, half of the upper part of the vagina. So these will fuse together and lead to the formation of a single uterus, two fallopian tubes, single uterus, single cervix and single vagina as well. Why does ovary doesn't come under this? Because ovaries are actually forming from the genital ridge. Ovaries have nothing to do with the Mullerian duct. So here we are discussing about Mullerian agenesis, where the problem is with the formation of the Mullerian duct itself. When there is complete absence of the Mullerian duct, there is going to be no female internal genitalia, no uterus, no cervix, no vagina, no fallopian tube. When there is going to be no uterus, the female will never experience any menstruation. So Mullerian agenesis is the first cause of primary amenorrhea when discussing about uterus. The second is androgen insensitivity syndrome, which is 46XY. As we all know, the chromosome of XX is what? XY is what? XX is for female, right? XX is about female. XY is about male. Now you may have the doubt that why 46XY and why are you taking this discussion under the primary amenorrhea in a female? It is because of the fact that it is actually a male. Okay, because the chromosome is 46XY. But the problem is with androgen insensitivity. Since these males are insensitive to the androgens, they will never have any features of males, right? So they will have primary amenorrhea. They will actually have female external genitalia and they will never have any internal genitalia as well. And these male patients are actually taken female at birth, right? Because they have female external genitalia. Because we all know that testosterone is very important for the formation of male external genitalia. If testosterone is present, then the fetus will have male external genitalia. If testosterone is absent, then the fetus will have female external genitalia. So since these males are actually insensitive to the testosterone, they will have a female external genitalia. And they will never have any female internal genitalia as well. So only the external genitalia is present, the internal genitalia is absent. So they will be taken as female at birth. But these patients, around the time of puberty, they will come to us with the complaints of primary amenorrhea. So we have broadly discussed about the causes of primary amenorrhea. The causes are hypothalamus Kallmann syndrome, pituitary is space-occupying lesion craniopharyngioma, ovaries are dysgenetic ovaries, Turner syndrome, Swyer syndrome, uterus is Mullerian agenesis, and then androgen insensitivity syndrome. What is the karyotype? For Turner syndrome, 45XO. For Swyer syndrome is 46XY. for Mullerian agenesis is 46XX. We have to have a female pattern, right? Mullerian agenesis happens in a female, so it is 46XX. Androgen insensitivity syndrome happens in males, so it is 46XY. Right? So we have discussed about the primary amenorrhea, the causes of primary amenorrhea, where is going to be the failure, whether it is in the hypothalamus, whether it is in the pituitary, whether it is in the ovary or the uterus. Okay, now let's discuss about the most common causes. Most common causes of primary amenorrhea. So in India, the most common cause is going to be what? It is Mullerian agenesis. So Mullerian agenesis, the karyotype, it is happening in a female, so it is 46XX, right? Yes. So Mullerian agenesis is the most common cause of primary amenorrhea in India. The second is going to be the gonadal dysgenesis. So where the patient will have gonadal dysgenesis? In a condition such as Turner syndrome. In a condition such as Turner syndrome, there will be dysgenetic ovaries. It is 45XO. And then in Swyer syndrome. In Swyer syndrome also, the gonads are dysgenetic. It is 46XY. So India, the most common cause is going to be Mullerian agenesis followed by gonadal dysgenesis. The exactly opposite is going to be more common in the world. When we take into consideration the entire country, it is only the Mullerian agenesis followed by the gonadal dysgenesis. When we take into consideration worldwide, the most common cause is going to be gonadal dysgenesis. So worldwide, the most common cause is going to be gonadal dysgenesis, which is Turner followed by the Swyer syndrome, and the Mullerian agenesis is the second most common cause for primary amenorrhea. Whereas taking into consideration India, the most common cause is Mullerian agenesis, which is 46XX, followed by gonadal dysgenesis. In India, Turner syndrome is not much common. Swyer syndrome is the most common, followed by the Turner syndrome. Right? We'll discuss about Turner syndrome, Swyer syndrome subsequent modules. But as of now, we have learned about what are the causes of primary amenorrhea and what is the most common cause of primary amenorrhea in India and worldwide. And also we have learned about different conditions which are affecting the hypothalamus, pituitary, ovary and the uterus. Now, what is our duty? Now, how are you going to manage a patient with primary amenorrhea? So let's say, for example, a patient is coming to me with complaints of primary amenorrhea. Now, what am I supposed to do with this patient? So first, what I have to do is I have to examine. I have to get a thorough history from the patient. With the history, I have to make some examination. What is the examination? I have to check whether there are signs of breast development being present in her, whether a breast is developed, and whether she is having external genitalia, whether there is female external genitalia being present. And I have to check whether breast is present as well. Okay. Yes. And here the most important point is that you are never supposed to do any pervaginal examination as well, because pervaginal examination is contraindicated. Right? Why pervaginal examination is contraindicated? So pervaginal examination is actually contraindicated in sexually inactive females. In other words, in a nulliparous female, pervaginal examination is actually contraindicated, right? Okay, so after physical examination, what am I supposed to do? In all cases of primary amenorrhea, we have to suspect pregnancy. Okay, so now I have to order urine pregnancy test for the female. Urine pregnancy test. And now, can someone tell me why pervaginal examination is actually contraindicated in a nulliparous sexually inactive female? In other words, virgin females. It is because they believe that it will lead to the tear of the hymen as well. Hymenal tear can happen iatrogenically. So, if I am going to do per-vaginal examination in such females are hymen bay tear. So it is a complication which is done by a doctor. Since it is done by a doctor, it is termed as iatrogenic complication as well. So I'm going urine pregnancy test. If urine pregnancy test is going to be negative. So now what am I supposed to do? The other tests which am I supposed to do are ultrasound. Why are you going to order an ultrasound? In order to check whether the female internal genitalia is present, whether the uterus is present, whether the fallopian tube is present, whether the cervix, vagina, ovary, everything is present. I need to check. First we check for whether the breast was present, whether the female external genitalia was present, and now with the help of ultrasound I'm going to check whether the female internal genitalia is present as well. And then what are we supposed to do? We need to check for the follicular stimulating hormone as well, in order to check whether the ovulation has happened or not in the female. Okay, so these are the basic investigations which we are supposed to do in a female. After doing all such tests in a female, what is the best investigation? What is the investigation of choice for any female with primary amenorrhea after these basic investigations such as UPT, ultrasound, serum FSH? After doing the physical examination is going to be karyotyping. Why? Because is that we have seen so much of genetic syndrome until now, right? So these genetic syndrome can actually be the causes. By doing karyotyping, we can actually find whether the female is having Turner syndrome, Swyer syndrome, Mullerian agenesis, or whether androgen insensitivity syndrome is present, or Kallmann syndrome is present as well, right? So karyotyping is actually done in order to find any chromosomal abnormalities, right? So for that purpose we are going to do karyotyping, and if at all required we can also do MRI of the brain in order to look for any between tumors being present such as microadenoma, macroadenoma, craniopharyngiomas, right? So MRI brain can also be ordered. Okay, so until now we have discussed about what are the investigations and what are the most common causes for primary amenorrhea as well, right? So now we'll divide these categories into two things. Primary amenorrhea in a female with uterus present and uterus absent. We all know that for the presence of menstruation in a female, uterus is very important, as well as hypothalamus, a function of the hypothalamus, pituitary, ovary, and the uterus is very important. So as of now we have discussed about hypothalamus, Kallmann syndrome, craniopharyngioma, gonadal dysgenesis as well. So after doing all these things, after ruling out all these things, now we need to take into consideration the karyotyping in order to find whether any chromosomal abnormalities are present in this female or not. Now let's classify this primary amenorrhea based on the presence or absence of uterus. So what are those conditions in which the uterus are going to be absent, and what are those conditions in which the uterus are going to be present, right? So in which conditions uterus will be present? So any condition which is not affecting the uterus, all those conditions they will have uterus. So let's take into consideration the hypothalamus. So definitely Kallmann syndrome, the uterus is going to be present, because in Kallmann syndrome the problem is with the hypothalamus, because there is hypothalamic failure. So because of hypothalamic failure only the patient is not menstruating. So there is nothing to do with the uterus. So uterus is going to be normal. So in Kallmann syndrome uterus will be present. Followed by what? Followed by in ovary. Ovary, what we discussed? We discussed about dysgenetic ovaries. Dysgenetic ovaries are present in Turner syndrome and Swyer syndrome. So in Turner syndrome and Swyer syndrome the problem is only with the ovary. It has nothing to do with the uterus. So uterus is going to be normal in, not normal, but uterus is going to be present. So uterus can be hypoplastic or it can be well developed, but uterus will be present in these conditions, that is Turner syndrome and Swyer syndrome. Irrespective of whether the uterus is hypoplastic or normal, in these conditions the uterus will be present, because the problem is not in the uterus in these conditions. In Kallmann syndrome the problem is with the hypothalamus, right? In Turner syndrome and Swyer syndrome, the problem is going to be with the ovaries because there are dystenitic ovaries. And we're going to discuss an important condition which is termed as cryptomenorrhea. So what is cryptomenorrhea? So cryptomenorrhea is basically a condition where a female is going to menstruate normally, but because of outflow tract obstruction, the menstruation, whatever menstruation is happening in a female, it is going to get collected inside the female's genitalia. So within the genitalia, or whatever menstruation is happening is going to get collected. So because of that fact, because of outflow tract obstruction, all whatever menstruation which is going to happen in a female during the cycle, all this blood gets collected inside the genitalia itself. So in cryptomenorrhea also, the problem is not with the uterus, it is only with the outflow tract obstruction. So because of that reason, in cryptomenorrhea also, the uterus is going to be present. Now let's type the karyotype of each and every condition. In Kallmann syndrome, as we have discussed, the problem is 46X6. The patient is a female patient, but the problem is with the hypothalamus, right? In Turner syndrome and Swyer syndrome, Turner's is 45XO, right? Swyer's is 46XY, and cryptomenorrhea is also 46XX because she is a female, right? She is a female, but the problem is only with the outflow tract obstruction. Since the blood has no path to come outside, the blood is going to get collected inside the female's genitalia. Yes, okay. Now let's take into consideration where the uterus will be absent. So only two conditions are there. One is going to be Mullerian agenesis. As we have discussed, in Mullerian agenesis, there is going to be absence of Mullerian duct formation. When there is going to be absence of Mullerian duct, then definitely there is going to be no uterus, no fallopian tube, no cervix, and no vagina. And the second condition is going to be androgen insensitivity syndrome. In androgen insensitivity syndrome, it is actually those are the male patient, but since they are insensitive to the testosterone is present in them, since they are insensitive to the testosterone, the female external genitalia is going to be present, because for the formation of male external genitalia, testosterone is very important. In these male patients, testosterone is present, but these patients are insensitive to the testosterone. Since they are insensitive to the testosterone, female external genitalia is going to be present in such patients, but male internal genital organs are not going to be present, and no female internal genital organ is going to be present. So any patient with no internal genital organs but female external genitalia is present with the karyotype of 46XY, those are androgen insensitivity syndrome. Ideally, they are male patients, 46XY, but because they are insensitive to the testosterone, they will have female external genitalia. So they are ideally taken female at birth. So at birth, they are going to have female external genitalia. So these patients are actually taken female at birth, and they are going to come to you at the age of 13 or 15 years as complaints of primary amenorrhea. So when you do ultrasound in these patients, you can see absence of uterus. So primary amenorrhea with uterus absent is Mullerian agenesis and androgen insensitivity syndrome. Again, Mullerian agenesis is 46XX. Okay, uterus present is Kallmann syndrome, Turner syndrome, Swyer syndrome, and cryptomenorrhea. Right? Okay, so 46XX, it is present in whichever condition. There are four conditions, actually three conditions. Okay, what are those? Cryptomenorrhea, because in cryptomenorrhea, what is the problem? The problem is with the outflow tract obstruction. So since they are females, cryptomenorrhea. And then Mullerian agenesis. In Mullerian agenesis also, they are females, but the problem is with the formation of the Mullerian duct. And then third thing is Kallmann syndrome, because in Kallmann syndrome, the problem is only with the hypothalamus. They have nothing to do with the uterus or other parts. So in Kallmann syndrome also, the karyotype is going to be 46XX. So cryptomenorrhea, Mullerian agenesis, and Kallmann syndrome, the karyotype is 46XX. Right? So until now, we have discussed in detail about what is primary amenorrhea and what are the most common causes in India, and what are the system wise. We have discussed about hypothalamus, pituitary, ovary, and uterus, and what are the investigations which have to be done in a female with complaints of primary amenorrhea, and we have classified primary amenorrhea on the basis of uterus present or absent. So this is all about primary amenorrhea. In the subsequent modules, we'll be discussing about all these separate conditions in detail. Until then, please keep studying, students. Let's meet in another interesting module. Thank you.